This is group 35 and we will be discussing a case of jaundice of 40-year-old male patient with chief complaint of yellowing of the skin and sclera and urine for 1 week.
History of present illness. He has no significant past medical history or liver disease or toxin exposure and denies any pain or recent infection, but complains of fatigue. He recently started taking herbal supplement for energy, which raises concern for drug-induced liver injury or hemolysis. His family history includes hypertension in his father and diabetes in his mother with non-liver or hematological disorders. He has sedentary lifestyle. He does not use recreational drug, but the new herbal supplement remain as possible factor.
Moving on to physical examination, we can see that the vitals are stable. In skin and sclera, jaundice is evident. Normal heart sounds were found and no murmurs or JVD is noticed. Abdomen appears soft and no tenderness or ascites were found, making cirrhosis less likely. No edema, cyanosis or clubbing were seen in the extremities. Lastly, the neurological and pulmonary findings were also normal.
Diagnostic workshop. Tests like complete blood count, peripheral smear, LFTs and bone marrow biopsy were done which showed anemia with high reticulocyte count suggesting hemolysis, spherocytes and polychromasia. High LDH and indirect bilirubin and low hepatoglobin also suggest hemolysis. Bone marrow biopsy helps out rule leukemia or myelodysplastic syndromes.
Now, moving on to the differential diagnosis. Now that we have confirmed hemolysis, the next step is differentiating the cause. The first differential diagnosis that we came up with is autoimmune hemolytic anemia, which was most likely due to the presence of spirocytes, reticulocytosis, and low hepatoglobin. The next differential diagnosis that we came up with is hereditary spherocytosis. This was considered because of the presence of the spirocytes, but there is no family history, and the hepatoglobin is also low, which is unlikely in hereditary spherocytosis, so we ruled it out. The next differential diagnosis that we came up with is hemolytic uremic syndrome, typically presents with bloody diarrhea, thrombocytopenia, and renal dysfunction, none of which was present in our patient. The next differential diagnosis is G6PD deficiency, and this can cause episodic hemolysis, especially after drug or infection trigger, but our patient has no recent oxidative stress exposure, normal G6PD level, and no hands, body, and bite cells were found on the smear, so that this also gets ruled out. Liver disease is the last differential diagnosis, and this also gets ruled out since the liver function tests were also normal.
Therefore, our final diagnosis is autoimmune hemolytic anemia. In this patient, we can see jaundice and dark urine because of ongoing RBC destruction and hemoglobin release. Here, we can see the laboratory findings also fit the pattern of hemolysis. Indirect bilirubin is elevated due to excessive RBC breakdown. LDH is high, supporting the hemolysis. Haptoglobin is low since free hemoglobin binds to it, and reticulocytosis shows the bone marrow is trying to compensate.
So let's dive into case discussion questions. Number 1. To discuss what are the potential causes of these findings and how would we differentiate between hemolytic anemia and hepatic dysfunction. It is very clear that jaundice and dark urine comes from hemolysis, liver dysfunction or biliary obstruction. Since this patient has elevated indirect bilirubin, the primary concern is increased RBC breakdown suggests hemolytic anemia and not hepatic dysfunction. To differentiate hemolytic anemia versus liver disease, we check liver function test. If LFTs are normal, the liver is functioning properly, suggesting hemolysis. Hemolysis also present with high LDH, low hepatoglobin and reticulocytes. All signs are of increased RBC turnover. Next one, the peripheral blood smear shows spherocytes and schistocytes. How does this help narrow the differential diagnosis? So let's see. Spherocytes suggest extravascular hemolysis seen in autoimmune hemolytic anemia or hereditary spherocytosis. Schistocytes are fragments of RBC indicating intravascular hemolysis seen in disseminate intravascular coagulation or thrombotic thrombocytopenic purpura or mechanical hemolysis. Since this patient has acute onset, no family history or recent herbal supplementation use, possibly cause include Number 1, the drug-induced hemolysis. Number 2, autoimmune hemolytic anemia. Number 3, microangiopathic hemolytic anemia, but no thrombocytopenia, making it less likely. Therefore, spherocytes gives us a suspicious of autoimmune hemolytic anemia.
Why normal LFTs rule out hepatic dysfunction? If liver disease were the cause, we'd expect direct hyperbilirubinemia with elevated ALT, ASP, and ALP. Since those were normal, it confirms that the jaundice is not from liver dysfunction but rather RBC destruction, which is hemolysis. Now, what would be our immediate management? We'll confirm and rule out other causes. Then we'll stop the herbal supplement, which was a potential trigger. We'll give supportive care, hydration, and monitor hemoglobin, bilirubin, LDH, and reticulocytes. Consider transfusion if anemia worsens, and second-line therapies for refractory cases. Additional tests for diagnosis and complications include hemolysis markers, direct Coombs test, G6PD enzyme assay, hemoglobin electrophoresis, bone marrow biopsy, imaging, and kidney function tests. Management based on underlying cause. Since our patient has AIHA, we'll start steroids, which is our first line treatment, and consider rituximab or splenectomy for refractory cases. If G6PD deficiency was there, we will avoid the triggers. If drug-induced hemolysis is there, we will stop the causative agent and give supportive care and monitor for complications. Key clinical takeaways. Our key clinical takeaways are that the symptoms jaundice, dark urine, and lab tests like indirect bilirubin increased and others made us think hemolysis, the treatment for which was steroids and splenectomy if it was refractory. Here are our group members, and that concludes the discussion. Thank you so much.